Hello, thank you. It's a pleasure to be here. I'd like to thank the organisers for inviting me to participate in this symposium. I will be presenting the primary outcomes of PACE A and PACE B on behalf of Professor Binnaz and the PACE trial investigators at the Royal Marsden Hospital and the Institute of Cancer Research in London. So I will begin with the primary outcomes of PACE B, which were a phase 3 randomised control study comparing SBRT to conventionally fractionated or moderately hyperfractionated radiotherapy in localised prostate cancer. These are the accurate disclaimers and disclosures for your reference, and these are the disclosures of the PACE trial investigators. So PACE was an umbrella study. It had multiple arms. I will be focusing on PACE A and PACE B today. There's also PACE C, which hasn't yet reported. This is in higher risk disease where androgen deprivation was given with radiotherapy randomization. So with PACE A and PACE B, this was in men with low to intermediate risk disease. If surgery was a consideration, they were randomized to PACE A to receive either prostatectomy or SBRT. If surgery was not a consideration, they were randomized to conventionally fractionated or moderately hyperfractionated radiotherapy or SBRT. Importantly, androgen deprivation was not permitted in A or B. So the PACE B trial schema, 874 participants were enrolled in the study. The eligibility criteria was T1C to T2C staging, Gleason less or equal to 3+4, and a PSA less or equal to 20. All patients were MRI staged, and androgen deprivation was not permitted. Randomization was completed on a one-to-one basis. Men either received the standard of care, which was conventional fractionation. At the Marsden at the time, it was 74 Gray with androgen deprivation, but because in PACE B there was no ADT, we went with a 78 Gray dose, slightly higher, which was the standard European dose. After the publication of the CHIP trial, we included 62 Gray, again slightly higher than the 60 Gray there because of the lack of androgen deprivation. The experimental arm was stereotactic radiotherapy, 36.25 Gray in 5 fractions, alternate days delivered to the PTV. There was also a secondary dose target of 40 Gray to the CTV, which was the whole prostate in low-risk disease and low prostate, plus a centimetre of the seminal vesicles in intermediate. The primary outcome was 5-year biochemical or clinical failure. Secondary outcomes were overall survival, prostate cancer-specific survival, and toxicity. Toxicity has already been published, the 2-year results in Lancet Oncology, but I will discuss the 5-year outcomes today. Importantly, PACE B was a non-inferiority study. We had 80% power to exclude a hazard ratio of 1.45 with a one-sided 5% alpha. This required 854 participants. The time point of interest was 5 years from randomization. This is how accrual went for PACE B. We started recruitment in August 2012. There was 874 patients, so we over-recruited. This was across 37 radiotherapy centres in the UK, Ireland and Canada. The data snapshot I'm presenting today is from the 11th of September, at which time point the median follow-up was 73.8 months. You can see in April 2016, there's a sharp increase in recruitment for PACE B. This is because PACE was originally a CyberKnife-only trial, and then sponsorship swapped to the Royal Marsden at this time point, and we included LINAC-based SBRT, and hence the huge increase in recruitment at that point. So to the baseline characteristics, they were well balanced between the two groups. The median age was 70 years, which is pretty standard for a radiotherapy study of this nature. The risk groups were predominantly intermediate risk. This reflects the fact that low risk is normally, we tend to manage this with active surveillance. So the men in this study did require treatment. So to the results. Primary endpoint was 5-year biochemical or clinical failure. You can see very high control rates up to 5 years. The orange line is conventional or moderate hyperfractionation, and the blue line is prostate SBRT. You can see they overlap, and there's no significant difference between the groups. Very high control rates of 94.6% and 95.8% at 5 years. So the biochemical clinical events in further detail, those 60 events overall, 35 in the conventional fractionated group and 25 in the SBRT group. This gave us the event-free survival of 94.6 and 95.8 from the graphs. The unadjusted hazard ratio was 0.73 and the confidence interval crossed 1 with a p-value of 0.04. So this shows, well, we have shown non-inferiority of SBRT to conventional fractionation or moderate hyperfractionation, which is what we set out to achieve. The absolute difference at 5 years was 1.44%. We also looked at 5-year toxicity. As I said, the 2-year toxicity has already been published, but we want to see what happens beyond 2 years. We assessed RTOG and CTCA toxicity. The first graph shows RTOG GI toxicity up to 5 years. The colours remain consistent, so orange is conventional or moderate hyperfractionation and the blue is SBRT. The top 2 lines are grade 1 toxicity, bottom 2 are grade 2 and grade 3. Because the graphs are quite crowded, I will focus on what's important, so grade 2 and above toxicity. You can see very flat lines, not very much GI toxicity all the way through to 5 years, and absolutely no difference between the 2 groups. RTOG GU toxicity up to 5 years, again, I'll focus on grade 2 and above. There's a slight increase in GU toxicity up to 2 years, but this wasn't statistically significant. And as you can see, as time goes on, the lines are almost overlapping with no difference at 5 years. CTCAE GI toxicity at 5 years, again, grade 2 and above toxicity, no difference seen between SBRT and conventional fractionation. With CTC GU toxicity, however, there was increased GU toxicity at 2 years with SBRT. This has previously been published, but as you can see, over the time, there is recovery and no statistical difference at 5 years. So in conclusion, to PACE-B, biochemical and clinical failure rates were very low across both arms. 5-fraction SBRT is non-inferior to conventional fractionation and moderate hypofractionation. Toxicity is very low for both groups. SBRT is more convenient for patients with shorter courses, and we predict it will be more cost-effective for the UK NHS and healthcare providers more widely. So I'll finish by saying SBRT should be considered a new standard of care in low to favourable intermediate localised disease. So I'll move on now to the primary endpoints of PACE-A. So this was a randomised controlled trial comparing SBRT to surgery in localised disease. So the rationale for PACE-A, men presenting with early stage disease have several treatment options: surgery, external beam treatments, SBRT, focal therapies, brachy. The great majority of these men treated radically with appropriate treatment will not die of their disease, so toxicity really does matter here. Treatment-related toxicity is a key deciding factor, and to our knowledge, PACE-A is the first and only randomised controlled trial comparing SBRT against prostatectomy. PACE-A trial schema, importantly, it was identical to PACE-B. If surgery was a consideration, patients either randomised 1-to-1 to prostatectomy or SBRT. We chose 2 co-primary patient-reported endpoints. EPIC scored urinary incontinence measured by any pad wearing, and EPIC measured bowel bother subdomain score. We expected urinary incontinence to be slightly worse with surgery and EPIC bowel bother to be slightly worse in SBRT, so we chose both not to bias against surgery. Secondary endpoints included acute and late patient-reported outcomes, acute and late clinician-reported toxicity, biochemical clinical failure, disease-free survival, and overall survival. This is the sample size, so we required 234 patients. This was calculated on urinary incontinence, so we expected 15% rates in surgery and 4% in SBRT based on existing literature and discussion with surgeons. We also had 90% power to detect a 5-point difference in EPIC measured bowel bother. Recruitment was much more challenging in PACE-A. We only had 10 UK centres. Recruitment began in 2012 also. It's often difficult to recruit to trials where the randomised arms are so different in their treatment strategy, and PACE-A was no exception. Then we were confounded really by the impact of COVID-19. And in February 2012, you can see that the accrual and the target recruitment are quite different, and we asked the IDMC to review the data. They advised at the time to close recruitment. We didn't know why, but it's because we already had quite significant results, at which time point we had 123 patients randomised to PACE-A. The baseline characteristics were well balanced. Again, predominantly the patients were intermediate risk disease. This is a consort diagram. I won't go into it in much detail. There was some crossover, but men mostly received the treatment they were allocated. So to the co-primary endpoints, the first one, urinary incontinence, you can see at 2 years with surgery, there's a much higher incontinence rate of 46.8% compared to 4.5% with SPRT. This is a highly significant result. Looking at urinary incontinence in closer detail, SBRT incontinence rates remain quite static across time points towards 2 years. You can see at all time points surgery has much higher rates of incontinence. This does improve over time, and about 6 to 9 months, it remains quite constant towards 2 years. It's also our measure EPIC 26 of urinary incontinence was any pad wearing, so one or more. Predominantly the men that were in this study who were describing incontinence were one pad, so 88%. So these men did not have gross incontinence, but still they required a pad a day for security, which, you know, it does come with burden to our patients. The second co-primary endpoint was EPIC measured bowel bother. Surgery, to mention in terms of the EPIC scores, 100 is a perfect score, no dysfunction. The lowest score is worst score. So surgery 97.3 and SBRT 88.7. So statistically worse SBRT bowel bother at 2 years, but overall sort of moderate levels of bowel bother. Looking at this in closer detail at 2 years, the top line is no bowel bother, which was the majority of patients. Patients with bowel bother with SBRT mostly had very small problems. One patient reported moderate problems with their bowels. No patients described a severe, i.e. a big problem with their bowels at 2 years. So I think overall, if you look at both co-primary endpoints, the results are in favour of SBRT. Another toxicity, which was important, although not a co-primary endpoint, was sexual function. Men were scored on the EPIC score, so 100 is a perfect score, lower score is worse. Surgery fared significantly worse in terms of sexual function at 2 years with a score of 29.3 and SBRT was 57.7. This is the sexual dysfunction depicted graphically. You can see a much larger drop in sexual dysfunction with surgery, which is the blue line here. Men did not have sort of perfect function at the beginning. You know, the baseline scores were not 100. The green is SBRT. You can see much more recovery towards baseline at 2 years. This is the EPIC subdomain scores summarised graphically. The most striking results are the sexual dysfunction and the urinary incontinence, which is worse than surgery compared to SBRT. Minimal worsening of bowel bother with SBRT and no difference in urinary obstructive symptoms. In terms of CTCAE GI toxicity at 2 years, there was minimal reported clinician GI toxicity with no difference between the two groups. There was also no difference in CTCAE-GU toxicity up to 2 years between the two groups. Overall, clinician-reported toxicity was very low, and if we had not done the patient-reported toxicity, we may not have found these widely different results. So in conclusion, case A, when men were compared with surgery, patients receiving SBRT had better urinary incontinence and less bowel bother, with a small trade-off in less sexual bother with a small worse bowel bother at 2 years. Grade 2 or worse CTCAE clinician-reported toxicity was rare overall. Efficacy data will be reported in due course, but as we know that the PACE-B results, we know this is a highly effective treatment. The eligibility criteria were identical across the two arms. So in conclusion, modern radiotherapy is highly effective with high 5-year control rates with SBRT, and SBRT should be considered a new standard of care in low to favourable intermediate risk localised prostate cancer. Thank you for listening. These are our thank yous to the participants of PACE-A and PACE-B, the trials team at the 37 centres, the ICR CTSU, and our senior collaborators. Thank you.